It really has to do a lot with the managing of the toxicities. So, for instance, a lot of my patients I'll give them gemcitabine, nab-paclitaxel chemotherapy to start off with. And the reason for that is because of the fact the nab-paclitaxel, even though it does cause a lot of neuropathy, the neuropathy tends to be more reversible. So after you stop the chemotherapy, at least the nab-paclitaxel, over the course of the next month, generally it probably will reduce down to less than a grade 1 for most patients. And the advantage with that is that once you actually have signs of progression and you go on to, say, second line nanoliposomal irinotecan and 5-FU, which you are able to get good control of the disease with that regimen, you're getting further and further away from the nab-paclitaxel neurotoxicity. Therefore, when you get to third line, you can think about incorporating in oxaliplatin into the regimen. And unfortunately with oxaliplatin, that neuropathy tends to be more irreversible. So for those really, really good performance status patients that you start with modified FOLFIRINOX chemotherapy in the first line setting, what I typically do is that I will actually drop the oxaliplatin chemotherapy as we're starting to see more neuropathy, because I really don't want that neuropathy to be really set in and permanent. Because if it's really causing a lot of problems where patients are having difficulty buttoning their shirts and doing activities, trying to give gemcitabine and nab-paclitaxel chemotherapy afterwards is unfortunately not going to be tolerated.